Right. Very good morning, good afternoon, and good evening, ladies and gents. I'm Vikas Kanduja, consultant orthopedic surgeon in Cambridge, UK, and one of the founders of SICOT Pioneer, and also the president-elect of SICOT. And it's indeed a pleasure to welcome all of you logging into this webinar from all around the world. Now, in the COVID world of non-contact domains, we've certainly embraced digital competitiveness with the launch of SICOT Pioneer. And through this platform, we've done over 76 events and have had over 100,000 views from 110 countries around the world. So a big thank you for joining in and following us as well. Now, today's webinar is a very important webinar for SICOT, and I thank Mr. Arindam Banerjee for allowing us to do this in partnership with World Orthopaedic Concern, and he's here today, the president of World Orthopaedic Concern. And also, we are ever so grateful to Professor Sasi and Professor Muhammad from Pakistan to facilitate this webinar with getting excellent faculty who've given up their precious time for this webinar. And I'll let Sasi and Muhammad introduce them to you in a minute. We'll try and make this webinar as interactive as possible. So please do post in your questions. And if you can't join us today, then you can access the webinar on our on-demand platform as well. Once again, a big thanks to the faculty, to World Orthopaedic Concern, and to all of you for joining us, and hope you enjoy the webinar. Arindam, over to you. Thank you.
Thank you, Vikas, for the introduction. And as you know, that World Orthopaedic Concern is a sister organization of SICOT, and we're also its humanitarian arm. So we thought this discussion about hand-holding, which we all know is very important in orthopedics, and medical outreach, which we all try to do, is very important to the values of SICOT. And I would like to hand over the stage to SASEENDAR and Muhammad, who can start the moderation by introducing the speakers and then letting them get on with their talks. Thank you.
Thank you very much, Dr. Arindam. Thank you, Vikas, for the introduction. Today, I would like to welcome you all for this very important webinar, and one which I hold very close to my heart. It is very important that we have to use the medical advancements that are rapidly evolving in order to help the less lucky or less facilitated areas and countries around the world. So I would like to invite Dr. Alberto Gregori. Unfortunately, right now, as we are speaking, Dr. Alberto is flying in Zambia. I hope he is available to clarify questions, but we have a recorded video of Dr. Alberto's presentation. So let me introduce Dr. Alberto. Dr. Alberto Gregori is from UK. He's an orthopedic surgeon and the chair of the World Orthopaedic Concern in UK. He's involved in global orthopedics since working as a missionary surgeon in Zimbabwe in 1985. He has worked in various countries, including Lebanon during the Civil War, and he is now retired but focuses on providing better orthopedic care to those less fortunate. He has donated all his royalties from his work in knee computerized and robotic surgery to WOC UK and FlySpec. Over to Dr. Alberto's presentation.
Good evening. I'm going to talk about reaching communities and exploring pathways in philanthropy. This is part of the hand-holding medical orthopedics outreach in the SICOT-WOC webinar. Who am I? I'm Alberto Gregori. I'm an orthopaedic surgeon with 40 years experience of working in low and middle income countries. I'm past chair of WOC UK and a trustee of FlySpec Zambia. I have no conflicts of interest to declare with regards to this presentation. COVID-19 pandemic really did show that we're a global village. And the Lancet report on limbic surgical access emphasised the huge lack of surgical access throughout poorer countries. This was a lack of resource, lack of manpower, and the significant impact that it has on the local population was highlighted. One of the things that isn't clear and isn't very obvious is the changing pathology. 40 years ago, the majority of pathology one would deal with in orthopaedics was infection, congenital deformities, and burns, for example, trauma playing a small part. However, now, the advent of Kawasaki disease and cheap and poor motor transport has caused a tidal wave of trauma, which is a huge problem, but it also costs more time and more money to deal with. Access to the already limited resource is not equal in terms of distribution. It often is capital-centric, with the remote and rural areas grossly disadvantaged. The point of care is often inaccessible to the patient and their families because of cost, distance, and often also the seasons. For example, the rainy season making roads impassable. So how do we address this? If the patient can't come to the surgical team, then the team has to travel to patients. That point of care resource might be a district or mission hospital, but it needs to have theatres and a willing staff. There obviously have to be beds, but sometimes even mattresses on the floor will suffice. There must be obviously a surgical and an anaesthetic resource in that hospital to make this work. Travelling depends on which country. Different countries have different solutions. Zambia, because of its huge size and distances and its sparse population, is best traversed by air, whereas Malawi, a much more compact country, can be easily reached by road throughout its reaches. India has proven the use of rail transport for camps very successfully over the years. The main focus of any of these projects, however, has to be education and capacity building. You teach a man to fish, you feed him for life. Teaching local staff isn't just about the one-off visit, but also the longer term, giving ongoing advice, often in a platform such as WhatsApp. We need to take trainees into the remote and rural communities. This opens their eyes to what happens, because often they've never been into remote and rural, having been born, brought up, and educated in the cities. But it also teaches them skills in terms of coping skills. It emphasises the need for clinical acumen and problem solving. The MRI scan and the CT scan isn't easily available and is perhaps completely out of reach of the patients they're dealing with. The real life and appropriate interventions have to also be tempered to the environment. Locking plates are practically impossible to obtain, logistically are difficult to support, and it may be we have to go back to old-fashioned techniques such as interlocking brush nails. One of the things we have to also consider is supporting the government, equipping young surgeons who are newly posted to remote and rural areas with the basics to apply their trade. This stops them becoming disillusioned in not being able to do what they've aspired to do for many years of training. Controversially, we also need to think about teaching private practice skills. Everybody needs an income, and by doing this, we also ensure that that skill set will remain in country rather than be taken elsewhere. All in all, this is really a long-term commitment and a relationship building which can't just happen over a long weekend. What have we learned from our projects in many countries throughout the world? Well, I think that most of the projects have to be locally owned and supported. We have to involve local businesses to support the actual camps in terms of kind, accommodation or transport, or supplying money for the food for the excess patients admitted to the hospital, paying for the anaesthetics, which are in excess of what is normally budgeted for. Maintenance is one of the biggest hurdles, and we need to teach appropriate maintenance skills to staff within the hospital. And this may well be just a simple handyman who's good at doing things rather than, in inverted commas, academic biomedical engineer who may not have any hands-on interest. Donations, which clearly we want to make and make us feel good, you really need to follow the KISS principles. Keep it simple, stupid. We should avoid a complex equipment, but it requires consumables to make it work and requires intensive maintenance. We need to source equipment from experienced limit-appropriate suppliers. For example, we need to have suppliers that know that anaesthetic machines that require compressed gases or piped gases are really unwieldy and unworkable in a limit environment where none of these things exist. We've also learned through experience that cheap and poor quality is always a mistake. You're better to buy less, but good quality, as it will last longer and survive the difficulties of the harsh environment that's being used in. We also need to think about training the next generation, not just training an individual, but training them to be trainers, building resilience for the future. There's no point in training one generation and leaving the next generation untaught and undeveloped. We've also found that taking trainees to Western countries for long fellowships is generally not a good idea. It often causes a desire to do things which are actually not supportable or appropriate in their home country, and this causes significant frustration. Success at the end of the day is about getting rid of yourself and not needing to be in the job anymore, because the local staff will now provide it. Zambian solutions to Zambia-specific problems require air transport because of the huge distances, poor roads and sparse population. We found that in-country and African fellowships with occasional short Western-term fellowships have worked well. In Zambia, we only have 2 surgeons who are out of country working with fly-spec. The remaining are all Zambians, and the centres are being visited are still expanding. Pilots actually remain our biggest challenge. I'd be happy to answer any questions by email if I'm not able to answer them directly at the end of this webinar. Thank you for your attention.
It's a very nice talk by Dr. Alberto. Now we are moving towards our next speaker.
Dr. Alaa, you are mute.
Okay. Do you want me to share the screen now with you?
Yes, please.
Okay.
Dr. Alaa will be talking on surgical missions impacting global orthopedic health.
Is it clear?
Yes.
Okay. Thank you for having me. And I'll talk about surgical missions related mainly to scoliosis, which I'm doing. And I'm a pediatric orthopedic surgeon, Palestinian, based in Ramallah, and I'm having a lot of global activities in South Asia, Southeast Asia, Africa, and Latin America. Most of them are related to implementing programs for scoliosis surgery. It's not going. Okay. So the problem of the missions, if you think that the financial resources are the issue, is the main issue in doing the mission. But the main problem is organizational resources. What we mean by that, equipped nursing and assisting staff, clear guidelines and protocols regarding medical errors, accountability, clear protocols about communication with different health institutions, incentives for data, and other things. So if we just go with the financial issue that we need to have implants and screws, then we'll go to the end of 90% of the cases that donor-volunteer exhaustion will happen, funds will dry up, and becomes clear that local surgical system is still stagnant with little lasting improvement to the surgical care quality or outcomes. And all what we have done is just doing some surgeries for 50, 60 patients, and that's all. And this is not right.
So we need to understand how we can implement and improve the organizational issue. And this, we need to understand the challenges for the local surgeon is that the weak organizational system imposes huge burden on the local surgeon, primarily which relate to training, learning. Surgeons are likely to be motivated or able to engage in high-risk surgeries because the surgeon is in a skeptic environment. There is a skepticism about his or her abilities, waiting for the expert surgeon to come. And if he or she do a mistake, nearly there will be slaughtered by everybody. So unless you understand this situation, you cannot understand the hesitancy of the local surgeon and how can you back him or her up. So global surgery, this will make a lasting difference. Missions not only provide clinical service, but also train doctors and advance their long-term capabilities. This will facilitate structural changes. You will not facilitate as an expert structural change. If you do it with the local surgeon, this will facilitate structural changes. And training should focus on knowledge, which means learning by doing. You know, nowadays we are having the internet and everybody can have the information. They don't need the information. They need to have the knowledge. And looking for champions is one of the most prior issues in your work. Whatever you would do, unless you have a champion, what mean by the champion? The champion is the surgeon who would have the burden on finding mentors, training opportunities, coordinating the requirements and opportunities of different healthcare organizations. Actually, the championship of this surgeon is instead of institutional fostering medical talent, like in developed countries, the medical talent arising despite institutional hurdles and insufficiencies. And this needs a really a motivated surgeon who knows what to do. And this is the only way that you can do it because 80% of the surgeons are based in 26 advantageous countries, and you must do whatever you can do to improve the local surgeons in this way. And the training program, once the training program is underway, you should receive a feedback from the group. It's not just the surgery. You need to have a feedback, and this is what always we try to do and push the surgeons to do. You must have a due date. You must know that, for example, I'll train surgeons to do scoliosis. Within 2 or 3 years, they'll be capable of doing 70% of the cases. Otherwise, it will be just some kind of reverse tourism. You'll come every year once or twice, enjoy it, and just go back home, and this is not right. So collaboration over hierarchy, the organizational burden and the decision should be part between the international and the local organization. It shouldn't be just doing that through the international organizations and putting aside the local organization as if I know better. And I did publish a paper in the JBJS in 2019 about the local and international surgeon relationship. Unfortunately, most of the time, if you don't believe that the local surgeon should be your partner, and stop having him or her as a prestigious assistant, this will not work. And you must, as an expert surgeon, believe in that and work on this way. And data and research is hugely important so as to evaluate yourself and to get the local surgeon to evaluate their work. What obstacles were preventing dissemination of pediatric spine surgery? It was neglected as a low priority, always thinking about malaria, TB, something like that. Short-term missions were an alternate to not to implement permanent pediatric spine management. Misconception about the high per unit cost of the pedicle screws. What has changed? Increased awareness of the importance of the problem, benefits of early management in scoliosis. Epidemiological shift, actually, even in the WHO, with global industrialization, gave importance to surgery. Since 2013, WHO improved their activities for global surgery. Global activity has changed from short-term mission, just doing some surgery, to building capacity, change in perception of highly specialized surgery, awareness of the effect of globalization, and we can see it in the COVID. And you must do the things that the local institute want you to do, and their priority. and you must go with them. For example, in Vietnam, like here we have a program in the Vietnamese German hospital. These people have 15 orthopedic spine surgeons, highly skillful. They have 7,000 spine surgeries per year in their hospital, but they focus on early onset scoliosis, and this is what they want. This is their priority. I'm doing that with them, and that's it. In India, for example, in Calcutta, we are having a program for many years now. And the main title of the program, of course, we don't need, of course, to talk about the intelligent Indian surgeons, but we are trying to implement scoliosis in a rural area. And in India, when you have huge rural areas, actually, it's a priority for the Indian doctors to know. And in Kenya, the program actually improved, and it's not just doing surgery, training them how to do the casting, halo pelvic traction, and this was with the collaboration of Gurki Hospital in Pakistan. And you need to think about some issues that are accessible to people. You don't just do surgeries having implants of $50 or $20 or $30,000 and do it and go back home. You need to think about priorities, how to make things accessible and appropriate based, scientifically based. And this is what we are trying to do with the active apex correction technique in early onset scoliosis. Artificial intelligence plays more and more role in training for the doctors. We did that in Nicaragua. You can see it's a software that you can guide the surgeon when you are abroad, and they can do the surgery safely. In Kenya, we are doing that, a proctorship program now. And this is a proctorship program. Actually, in Nicaragua, the issue is that I just went twice to do surgeries, to do missions. And in the third time, it was the first time that the Nicaraguan surgeons did the surgery. I guided them in the first surgery. I was in Vegas. I was in Ramallah in the second surgery. And the third surgery, they didn't ask for me even to do the surgery. And this is the trophy. And you need to go through the people who are heavy decision makers. You know, sometimes the locals, especially from the West, think that lobbying in the West comes to low middle income countries. There is no lobbying there. Either the Ministry of Health or the university, or you wouldn't have anything. So try to go and open with them and do like blended learning courses, even like the Pioneer Here program. And democratizing medicine, it's not just having access to service to the children. The true democratization of medicine is giving the chance to the people who do the health activity, the health workers, to be like you and to do the programs, because they will give the tools to go to the people who are poor people in the countries. Like what I'm saying here, Henry Ford didn't invent the car. Henry Ford get the car accessible to the middle class. This is what we are trying to do, to get the knowledge and the skills to the local doctors who can do that and have access to the poor people in all over the world. And the beauty about global activity is to have friends. Like, for example, on the right side, these are the girls that I did surgery in Nicaragua, and they gathered to say hi to me. And on the left side, from Rwanda, they knew that I'm in Kigali. They traveled 200 kilometers. This is a girl and her aunt whom I did surgery. Also, the best thing is to reshare information and knowledge with great experienced people from all over the world. And I have the quote from Kofi Annan. It's the aspiration of health will not be just a blessing. It's part of the human rights. And this even will change us as doctors to remove any prejudice or stereotyping ideas with the power of experience. And this will make us, even us, better in humanity in our work. Thank you very much.
Thank you very much, Dr. Alaa. I definitely had a lot to learn from your presentation. It is serving in difficult situations is an art, and we should also do a lot of planning to make sure the outreach program that is being conducted with a lot of difficulty actually makes a lot of benefit to multiple generations to come. Thank you very much. I would like to next invite Dr. Arindam Banerjee to talk on empowering through education, training orthopedic professionals in underdeveloped region. Dr. Arindam Banerjee is consultant orthopedic surgeon from Kolkata. He specializes in acute trauma, polytrauma, and arthroplasty. He is the president of the World Orthopedic Concern and past chair of the SICOT Education Committee. He has a lot of accolades in his academic career, including multiple lectures and publication of a major reference work. Over to Dr. Arindam Banerjee.
Okay, Alaa, if you could just stop sharing the screen.
It's stopped.
Thank you, SASEENDAR, for the introduction. Let me first share my slides. If you could, Alaa, you need to stop sharing.
You can share.
I'm sorry, I stopped Arindam immediately after finishing. Actually, okay, but it says you are viewing. Sofian, can you do that? Because it says you are viewing Alaa Azmi's.
Actually, I don't share a screen at all.
Nobody's sharing it.
I think you need to click a button there.
Sofian, we will go ahead with the next presentation before we can call Dr. Arindam again.
Yeah.
So I would like to, Dr. Pito is here. Okay, can I request Dr. Andrew to be ready with this presentation? I would like to invite Dr. Andrew Kent to talk on his presentation on orthopedic disaster response, mobilizing aid in crisis. Dr. Andrew Kent is orthopedic surgeon from UK, from NHS Highland. He is surgical director at UK medical advisor at Harlow Trust. He graduated from Edinburgh University Medical School. He is a former Royal Army Medical Corps officer. He runs trauma fellowship in Baltimore, USA. He is consultant at NHS Highland and has been engaged in training and humanitarian work for many decades. He is also the recipient of RCSCD 2020 Tuanku Morris Fellowship. Over to Andrew Kent.
Thank you. I shall just try sharing my screen.
Yeah, please share your screen.
Okay.
Yes, perfect.
Thank you. Mobilizing aid, and today we'll concentrate on surgical aid, is not easy in a crisis. I do not have a cut and paste solution to give you. And the key to preparation is to preparation. I'd like to consider long-term and short-term preparation. I'll also briefly compare and contrast both man-made and natural disasters. I'll emphasize the need for careful logistical planning and refer you to the guidelines and minimum standards that have been set out by the WHO. Preparing an emergency medical team for deployment is a long process, escalating exponentially when the call to deploy comes. This preparation is both team-based and individually based. In this brief talk, I'll concentrate on the team-based preparation. As I will discuss, the nature of sudden onset disasters is not completely random or unpredictable. However, any plan must remain flexible and adaptable, both prior to and during the mission. As the Vice Chair of the Faculty of Remote, Rural and Humanitarian Healthcare at the Royal College of Surgeons in Edinburgh, and also as the surgical lead for UK Med, which is the UK's emergency medical team, I'd like to highlight this free online course introducing humanitarian healthcare. As I mentioned, sudden onset disasters are not completely random and tend to occur in resource-poor regions. Add to this climate change, population drift, and other geopolitical issues, and it's not surprising that the incidence and the severity of sudden onset disasters is increasing. Historically, the international medical response to such disasters has been ad hoc and poorly coordinated. In some occasions, it has, quite frankly, made the situation worse. The WHO Emergency Medical Team Initiative was set up to try and rectify this using these 5 main pillars. And this has led to the publication of the Blue Book, classifying minimum standards for EMTs responding to sudden onset disasters, and also the complementary Red Book for teams responding in more hostile environments. This Red Book, serendipitously, has predated the ongoing conflicts in Ukraine, Sudan, and Gaza. When responding to sudden onset disasters, we can, to some extent, anticipate the numbers and types of casualties and plan our initial response accordingly. However, we should also remain flexible and adaptable to subsequent events and needs, such as unexpected civil unrest or disease outbreaks. We should consider mass casualty management and remember that routine emergencies will continue, particularly maternal health, such as cesarean sections. In conflict-related missions, the treatment options for the civilian population differs vastly to that in the military setting. Nowhere has this become more obvious than currently in Gaza. As you see here in this slide, in the military scenario, often we're dealing with single casualties who normally have very good physiology. They're injured by penetrating or blast injuries, and it's often the limbs that are injured in isolation due to them wearing body armor and protective helmets, etc. They receive rapid treatment, transfer for damage control surgery, and almost unlimited resources. The civilian population, unfortunately, are often multiply injured with mass casualties. They have very poor baseline physiology, and they suffer blast and crush type injuries. There's a high proportion of women and children, and that makes for some very difficult triage decisions. The facilities are resource poor, and there is sometimes no evacuation chain. And also, as I mentioned, we should consider routine obstetrics emergencies. Unlike conflict situations where there are multiple ongoing traumatic events, in natural disasters, there is usually one cataclysmic event which leads to a huge spike in healthcare needs. However, even the best prepared emergency medical teams will often arrive in country too late to deliver life and limb saving surgery. And we should expect and plan to manage the complications of injuries, the rehabilitation, and to support the local healthcare system. This requires a significant logistical input. To be able to deliver this type of aid, emergency medical teams need to have planned and prepared and rehearsed together to maximize their immediate effect once deployed. In the British military, we talk about the 6 Ps, the prior planning and preparation which prevents poor performance. We should also consider the 6 S's, the logistics support that we need. We need to have the systems in place, such as the standard operating procedures. We need to have appropriate staff. That's not just the surgeons, but the anaesthetic staff, the rehab staff, the nursing staff. We need to have the stuff, the equipment, and the space in which to operate. That space can be a standalone facility, but increasingly we are embedding surgical teams with other emergency medical teams, or occasionally embedding them in a local healthcare facility if these are still operational. And we must remember to support the team in country and to provide security and safety. Generally speaking, we want to deploy self-sufficient for at least a 14-day period during which the team is not reliant on the host nation to provide resources for the personnel or resupply to the hospital facility. Put simply, it's all about the logistics of getting the right trained people with the right equipment to the right place at the right time with the right support. And, of course, getting them home again. So in this brief talk, I really want to talk about the long and short-term preparation which is essential and the logistical support that requires. We need to practice as a team before deployment, but on deployment, we need to remain flexible and adaptable to the situation. It's also essential that we consider the exit strategy, not just of the team itself, but an exit strategy for the patients that we've been managing whilst in country to ensure that their long-term management continues. Thank you very much.
Thank you very much, Dr. Kane. It was a very nice presentation and we enjoyed a lot your presentation. I would like to invite Dr. Arindam to start their presentation and hand over to you, Dr. Arindam.
Okay, can you see me my screen?
We can see your screen, but not in slideshow.
Okay, just a second.
We lost the screen share. Yep.
Something's wrong.
You can double click on the first slide.
Okay, can you open my slides, SASEENDAR? Is it possible?
Okay, I'll do that.
Yeah. Something is wrong. Something is not.
No, it is.
Okay, please. Okay, yeah, that's fine. Right. Sorry about the screen freezing the last time. So I am Arindam Banerjee. I live in Kolkata and I'm part of the World Orthopaedic Concern Group. Next slide, please. Next, please. Now, it's a pleasure to share the SICOT platform because World Orthopaedic Concern is a sister organization of SICOT and we are its humanitarian arm. Now, I would like to talk today about empowering through education and training. And here we are talking all about North-South collaboration, South-South collaboration, and sometimes even collaboration within the country. Now, we all know that learning practical surgery is an apprenticeship. It's almost impossible to be an entirely self-taught surgeon. You have to have a guru somewhere in your long years, someone who has taught you the basics and someone who has taken you along. A brilliant surgeon may have the knack and aptitude for surgery, but without repeated practice and application, these skills will neither be developed nor retained. And there was, in fact, the practice is so important that there was a joke in our time during training that who is the better surgeon, the one who's working very hard and needs a holiday, or the one who's come back from holiday? And the answer was obvious. The one who's been working hard, who's been doing surgery from morning till night, is the one whose hands are in the best shape. And we all know that surgery is about having attention to detail. Next slide, please. Now, another joke we had was that when we were learning surgery, that you watch one, you assist one, you do one, and then you teach one. But of course, one is never enough. So what is enough? Now, there's been a lot of talk on this. For a violin player, what is enough? And people have come around to this magical figure of 10,000 incidents, like 10,000 steps, 10,000 hours of practicing, 10,000 doing one operation 10,000 times. But that is not possible in orthopedic surgery. We have 208 bones to attend to, so it's not possible to do 10,000 of each. And unless you're just working in a very narrow spectrum, perhaps doing hand surgery or only doing knee arthroscopy, then in that case it might be possible. But for our group of people and those who are teaching, the people who need to learn, I think you have to do less numbers, but you have to build up your skills. It's also not only about numbers. Repeated failure can happen after making the same mistake again and again. And if you're getting the same repeated bad result, it's better to try and understand if your surgical principles are wrong. So it's very important in this situation to understand that prolonged apprenticeship under a good guru is vital. And how can we do that? How can we empower the surgeons of the next generation or from countries who don't have the skills to take their agenda forward? Next, please. Now, Tolstoy said that all happy families are alike, but all unhappy families are unhappy in their own ways. So we have haves in orthopedic surgery and we have nots. And in India, I think in one generation, we have seen centers moving from having nothing to moving and becoming advanced centers. So we have seen the process and we've seen how it develops. And the characteristic of trainee surgeons in a developing nation or a training course is almost the same. There might be, the training is usually unstructured. There is an incomplete knowledge of understanding surgical principles. There may be less number of accredited and recognized qualifications. Qualifications are important because often people are doing surgery without being given the qualifications, and that actually halts their progress. These countries or these regions have less resources and less money, and they have lesser role models. So the trainer who is training may himself not have had structured training or may not have completed his or her training. And of course, sometimes there are issues of corruption. Next, please. So when one is looking at training or teaching, then the first thing is to identify the needs of the region. The group might have specific needs. They may have specific types of diseases. And it's important for the trainer to understand, does he have enough expertise or knowledge in the area of instruction? So the trainer may be a very good arthroplasty surgeon somewhere in the West, and the problem they might be facing might be something to do with osteomyelitis. So the person concerned has to be sure that he has the adequate knowledge in the area. And having done that, based on the time of teaching available, then a practical and appropriate curriculum has to be made. So if 3 years are available, then 3 years the course will be different from if 6 months or a year are available. And then after that, there of course have to be a number of didactic lectures, theory classes where the principles of surgery as well as operative surgical steps are explained. Videos and photographs, diagrams of the standard procedures, starting with casts, slabs, orthosis, are important. Remember, these centers are not very developed. Before they proceed to doing arthroplasty or advanced trauma, they need to know the basic skills. They need to know how to give relief, how to give some kind of support to the patient, medical, surgical, whatever it is. And after that case reports, appropriate case reports and videos along with x-rays and scans are required to create interest. When the trainee also has to interact, so journal clubs, I think, are essential, and they too need to do their case presentations, and they have to think about rational problem solving. Access to resources such as other websites and webinars also need to be done for the trainees, because these are freely available today on the net, and it's possible for everyone to access knowledge from all over the world. And finally, rehabilitation of the patients and practical physiotherapy need to be incorporated. Now, the points I've discussed here are all virtual things. These can be done on a computer, it can be done on Zoom, it can be done on various other platforms. Next, please, next slide. But of course, that is not sufficient for surgery, because surgery, again, as I said, it's a very practical specialty. There's only so much you can do by Zoom and so much you can do virtually. So some kind of actual practical training has to be incorporated, and this handholding has to be done either by the trainer or one of his team, who will have to make a periodic visit to the region. For instance, I know Alaa is doing this. He's visiting and revisiting several centers every year. And then the trainer, possibly when he reaches the center, the trainees or the senior surgeon there will tell him, look, these are the operations you need to do, and these are the problems I have. Then based on that, they have to make a plan. This plan should, of course, not be a utopian plan. It should be based on the resources available. And in certain cases, the trainer himself may have to innovate, because he may not have solutions, to the problems that he's facing. So there has to be a certain degree of thinking out of the box. Most trainers are, important, and they're very senior surgeons, so they have themselves resources to mobilize. They can immobilize implants or equipment. Sometimes these implants can also be mobilized locally, and sometimes when the government knows that someone important is coming, they also make equipment and implants available. The junior trainees, of course, have to train with the person training them. They need to learn the procedure, and if the trainee is a little bit more senior, or perhaps a surgeon, then they can do their own surgery with the trainer taking them through the surgery, through the difficult processes. And of course, again, we should not forget that there has to be a plan for aftercare, because it's all very good to go to a place and do lots of big surgery, but the patients should not be abandoned. So they need to be looked after, they need to be followed up so that they get appropriate results. Next slide, please. Next, please. So this is one way when the trainer goes, but then often that is not possible. So there could be the reverse way. The trainee could be taken to the more advanced center through a fellowship. This is the easier way, but there is a problem. Once the trainee reaches the advanced center and learns surgery, there's often a tendency that they may not want to go back to their original center. They might want to settle abroad. And even if he returns, he may not again have enough experience to work with the limited resources he faces. So it's important to understand that all these problems cannot be solved externally. The limited resources region trainee will have to solve most of their own surgical problems internally. And I can give you examples from my own career that when I returned back to India, and we were starting a new hospital, a tertiary center in a remote place, and we ourselves were relatively junior. I was only 35 years old. Then what we did is 2 of us consultants used to scrub for one case, and so that we had double the amount of knowledge and help available. So it wasn't that we were working with registrars, we were working with colleagues, and the other way around. Another thing which we did was that we didn't have enough junior staff, so we created a tier of orthopedic technicians who, though they did not have the qualifications, were actually very good at practical work. So these are two examples. There are hundreds of other examples which we did because we came back to India and set up a hospital, a group of us, and we are all quite young, between 30 and 35, and we took it to quite a high level. So, I mean, it is very possible and practical to do it. Next slide, please. So, to summarize, hand-holding is a very important part of surgical training and it can't be avoided. We all need people to hold our hands when we are juniors or middle grades, but we also need to hold the hands of others when we become seniors. Now, while external trainers and coaches are essential for developing skills in underdeveloped countries, it is also important that most of the problems need to be solved by internal motivation, enthusiasm, and appropriate innovation. Nowadays, in the past, we used to have North-South collaboration, which means that developed countries used to donate their time and energy and money to the lesser developed countries. But nowadays, even in developing countries such as India, we have a lot of resources, we have a lot of extra manpower, we have skills. So even we are able to donate to other countries who are not maybe at the same level of sophistication yet. And we are very happy to do that. I think India, in many ways, I've seen it happen in front of my eyes, that from the late 90s, when I started work, to 2024, we have been able to develop our own work from very basics to now tertiary care in orthopedics. And I think such a model can be replicated elsewhere with motivation, enthusiasm, and innovation. Thank you very much.
Thank you very much, Dr. Arindam, for a very detailed presentation of how to carry on the screening during surgical outreach. We have Dr. Peter Biberthaler. Dr. Biberthaler will join from his OR. I would like to invite Dr. Peter.
Sorry that I'm late. I just come out of the OR.
Do you like to start now, or you want some time?
Yes, no. I can do this. Just a second. So I will share screen, huh?
Yeah, just give me a second. Okay, so let me give a few words about Dr. Peter Biberthaler. Dr. Peter is orthopedic surgeon from Technical University of Munich. He studied at Ludwig Maximilian University Munich. He is director of trauma surgery at Klinikum Isar. He is leading AO trauma surgeon since 2019 and an expert in innovative implants, traumatic brain injury biomarkers, and complex joint fractures. I'd like to invite him to talk on innovative solutions in surgical outreach. Over to Dr. Peter.
Okay, I try to. Can you see my screen?
Yes, clear.
Okay. So, hello everybody. Sorry that I was late. So this is my talk. So I will talk about innovation solutions in orthopedic charity, and which is a very interesting talk. So I want to give you a short overview and then explain the importance of technology in modern healthcare. So as we all know, the importance of technology in modern healthcare is depending on several topics. It's depending on surgery, of course. It's depending on informational technology, telemedicine, custom prosthesis, 3D printed prosthesis, surgical guides. So this is an example for OR technology, and this is, for example, a project where it's called Surgical Africa, where UK-based charity organizations try to improve the local OR situations in states who cannot provide this for their own. So you see that there are a lot of people, but some of the technology equipment is not on the latest. However, I think they will do a good job because there's everything you need at the end. And this is also something, this is also a UK-based charity organization. And the problem about orthopedic injuries worldwide is that there are, especially in the countries where the people do not have too much money, the amount of orthopedic injuries is very high because people drive with two-wheelers and they drive in a kind of dangerous manner, so they have a lot of injuries and they have no insurance system, so everybody has to pay for its own health. And in this system, of course, many people cannot afford to have expensive operations. So this is one of the charity organizations where you can ask for help if you want to have orthopedic foundation. Then I think from the charity point of view, telemedical developments will be one of the most changing things. So this is one project. It's called the Virtual Doctors. It's also UK based, and it's a remote contact to physicians in UK, and it's a very successful program. So many patients were treated, and you can look here on the homepage how you can get involved into this project. But I think this telemedical issue is one of the most important development of bringing good orthopedic surgery also into remote areas. Custom-made prosthesis, of course, this is an important thing, and this is a foundation which is providing custom-made prosthesis in the United States. And as you can see, also these things are very expensive. So you can apply for this 3D printing technology. Then I think that these kind of mobile health applications will be also a very important project in the future for bringing orthopedic surgical care to remote areas. So you can see on the right-hand side, this is a kind of container OR, and this is a very good option to bring very good surgical procedures also into very remote areas without building complete new hospitals. So you just have a container and you put it there and then it runs. Then robotics and IA, I think this will be one of the most important things in the future, that we have surgical robots who are probably remote steered or work autonomous. So I think the remote steering will be for the next 20 years the most used procedure. So you have probably a surgical procedure somewhere in Africa, and the surgeon is sitting in India or in the United States and is doing the surgery remote. So this is an example for such a project where telemedical support helps in countries with low local medical standard. And then I want to draw your attention to a very interesting project. It was called Zipline. It was a drone application underneath of the whole of robotic and autonomous working technologies. And it was first used in Africa. It was used in Rwanda to bring blood with an autonomous flying system to very remote areas. And this has now, you see, it has spread all over the world, and you can bring everything using these kind of drones over a far distance, and it works extremely sufficiently. Virtual reality, which I think is also an important thing. So surgeons from remote areas or where the training is too expensive, they can make courses, online courses. And I want to draw your attention to this Orthopaedic. It's an online board, let's say a surgical atlas where peer-reviewed surgical procedures can be seen. It's extremely cheap. I think it's €6 per month. Everybody can access on it, and you can see all the surgical procedures very, very, very detailed, step by step. So I recommend everybody who has not the access to expensive surgical training programs, you can really learn a lot from these pages where you see a lot of surgical procedures. And the good thing, the advantage of this project is compared to other projects which are founded by industrial companies, is that there is no industrial money, and it's peer-reviewed, and you see all the scientific societies who are supporting this. It's UK-based, and now the German society is also jumping on the project. So we support this a lot. Okay. Then these are other ideas, probably blockchain for transparency, but I think this will be potential things in the future where we might bring orthopedic care also to remote areas. So this is an example how you can do this. I explained already such container surgical things. So you have this truck, you can drive this truck anywhere you want, and it's a ready-to-use orthopedic OR with an awakening room and with a sterilization room. So you have everything here in the whole process. Okay, ciao. Sorry. Okay. Hallo? Aber jetzt wenden Sie sich an Ihren Oberarzt. Ich halte hier gerade den Vortrag, okay? So, jetzt geht's hier mal weiter. So we go on. So you see this is a truck where you can take care of surgical procedures, also in remote areas. And of course, I also want to draw your attention to the SICOT homepage, because I think it's really a very good option, and it has a special education program for also remote countries. Thank you very much, and now I'm open for questions.
Thank you very much, Dr. Peter. It was very nice talk, and it was very nice talk, and thank you for your time to make it possible during your hour. So I want to invite Dr. The last talk, which is not the least, the very important talk on the topic of the measuring outcome, evaluating the effectiveness of the orthopedic philanthropy. I want to invite our speaker, Dr. Ashok Johari. It is well-known Indian orthopedic and spine surgeon. He is not famous not only in India but around the globe. He is the director pediatric orthopedics from the Max Novartis Super Specialty Hospital from Mumbai. He is the pioneer. He pioneered the pediatric orthopedics in India. He is the past president of SICOT, IFDOS, and several other organizations. He is the chief editor of Journal of Pediatric Orthopedics, and he had published 7 books, and he has a numerous research paper on the field of pediatric orthopedics and orthopedics from India and around the world. So I will hand over to Dr. Ashok Johari.
Thank you very much, Dr. MUZZAMIL, and I am going to speak on the impact of philanthropy as related to orthopedics. So it's last and not the least, I think this is very, very important. How do we measure impact, of orthopedic philanthropy? Well, in general life, how do we measure impact? So if you are working hard, how do you measure impact? Your finances increase, you lead a more comfortable life, you have a new big house, you have a plush car, your children go to the best schools. Well, that's the impact, of working hard. But is it that easy to measure impact in terms of orthopedic philanthropy? No, it's very, very difficult because the yardstick is different for each mode of philanthropy. There are three pillars of orthopedic philanthropy. One is, of course, patient care, then education and training of surgeons and of the patients, creating patient awareness and education. And the third pillar is research. And how can you have a common yardstick to measure the impact of all these areas vis-a-vis orthopedic philanthropy? Well, let's look at patient care first. There's a lot of heterogeneity around the world, and different governments are making different efforts all around the globe, but the governmental organization often lack accountability and consideration of impact. Hence, there are newer ideas, methodologies, delivery systems, and policies which are needed. Philanthropy makes a huge difference if it is well targeted, well managed, reaches the user it is meant to reach, that is, it is well monitored, and when this happens with the right partners. Well, questions about evaluating healthcare and how good healthcare has plagued surgeons for a long time, and this is the Donabedian model for quality of care formulated in 1966 in a paper. Well, there are three areas which were considered important: the structure of care, the processes of care, and the outcomes. So you have, for example, a delivery system characteristic, which is a structure, or a provider characteristic, which is also a structure, or population or community characteristic. Then the process of care, which is of more medical interest, to the technical processes of how healthcare is provided, the care processes and the interpersonal processes. Then the outcomes measured in terms of health status, functional status, satisfaction, mortality, and cost. When you have a positive impact, you have a wider reach, you have ease of service delivery, you have cost effectiveness of that service, then you have functional improvement for the patients and an enhanced quality of life. When you have negative impact, it is because of lack of follow-up or lack of continuing care, lack of multidisciplinary resources. Well, the healthcare is cost ineffective. There is morbidity and there's poor quality of life despite interventions. So the underlying important question is, can we make a positive difference in the lives of our patients? Can we make them more productive? And can we benefit society directly or indirectly? Now, you can make different yardsticks, different parameters, but it all boils down to this, as to how effectively you could do or how effectively you could create a difference in the lives of patients with the minimum amount of resources and minimum cost. Looking at education and training, I mentioned it was for patients as well, patient education as well as surgeon education. Well, impact of an educational or a skills activity is based on feedback. For example, how many surgeons benefited? How many have started doing a procedure that they were not doing? Most impactful are fellowships, skill labs, cadaveric courses, video training, surgical simulation, virtual reality, etc. So there are many, many modalities by which education can be transferred. What is important for both these areas of patient care and for education and training is long-term feedback. This is at the heart of measurement of impact. Now, research is a different kettle altogether. Impact is based on wider applicability, potential to benefit mankind, publication of this research post peer review, citations, papers and patents or intellectual property generated, its innovativeness of that research and entrepreneurial potential. Now, I give you an example of a simplified scheme for measuring impact. On the top, you have these 4 areas called activity, input, output and the impact. For example, you have a fixed input of 5,000 euros, activity patient care. If you have 100 satisfied patients wherever in the world, the impact is high or maybe very high. Education, the same amount of money, you have 10 trained surgeons, the impact still will be high. And research, you have 5 well-cited papers, the impact is still high. Of course, this would be based on that particular population. What is the priority of that population? What is relevant to that population? So, if patient care is more important, I think research will be put aside as is happening in the underdeveloped world, because first of all, patient care and education of surgeons become very, very important. Education of patients become more important than the research priority. So impact of philanthropy is also difficult to measure as it takes years to see the end results of such pursuits. We can talk of early, intermediate, and long-term results and their impacts. Impact, however, is essential for us to know for guiding our future activities. So to summarize, impact of any philanthropic activity is difficult to measure. It will depend on the mode of activity for which philanthropy is utilized. Each activity will have its own impact measurement, and feedback is a very important parameter. And impact considerations are very, very important, especially for the future course of philanthropy. So that was a short presentation on impact of orthopedic philanthropy. I thank you very much for your attention and would welcome any questions.
Thank you very much, Dr. Ashok Johari. That was a very important and nice presentation. We could learn a lot from it. First, we have some questions for Dr. Alaa. There's a question from the audience. So how do you deal or how do you train the local orthopedic surgeons to deal with surgical complications? And if they are not trained enough or not knowledgeable enough to manage a particular complication, but it has arisen, so how do you deal with it?
Yes, it's a very good question, actually. And I want to say for a complex surgery like scoliosis, I prefer to have 2 people, beginning with orthopedic and neurosurgeon. And usually these people deal with trauma but they don't deal with deformity. So they have an idea in general, but the neuro and the orthopedic will help each other in the process of the training and in dealing with complications. Another issue is that don't ever begin with complicated cases, because if you begin with that, you'll just do it by yourself and you'll not train them. This is the major difference between missions that are focused on training and missions that are focused on just service. Like, for example, I would begin with 90 degrees, doing a lot of osteotomies. It's impossible to train people. So you begin with the basic, doing adolescent idiopathic, 50 to 60 degrees, until they are very well established in doing that. Then you can go upwards. So with this beginning, you can begin with cases that have least complications. Beside that, if you understand that scoliosis or like a complex surgery is not a one-man show business, you need to talk to the intensivist, you need to talk to the anesthetist, you need to talk to the pediatrician, so as to decrease the complication and aware them about the whole process. Because sometimes the complications are not surgical. They didn't know that this child who is syndromic is having a problem that he might die on the table or she might die on the table. They don't know that after surgery, the hemodynamic balance must be assured by some procedures and they must be put in the... So these are the issues. And then you raise the bar gradually. This is how we try to do it. And beside that, now we are lucky enough that we are in a world of this phone, that they can just get a WhatsApp and show you the X-ray of the patient or something, and the artificial intelligence issues. So these are the issues that you can look at. And beside that, one last thing, it's preferable. If you want to go to do a program that you begin from scratch, it's much better to do 2 sessions per year, not 1 session, so as to decrease the time for the training.
Thank you very much, Dr. Alaa. Thank you for sharing your experience and the fine points. It is definitely better to prevent complications rather than to treat complications, and it is also important to prime not only the patient but also the staff who are going to work with you so that they can manage issues better. There's one question I would like to shoot to Dr. Alaa and Dr. Ashok Johari. How do you, Dr. Ashok Johari, how do you manage the logistics of transporting equipment?
स्टॉक मार्केट वाले लोगों की सबसे बड़ी प्रॉब्लम है कि उनका पैसा जैसे ही खत्म होता है दूसरे बंदे से उधार ले लेंगे, क्रेडिट कार्ड से उधार ले लेंगे, पर्सनल लोन ले लेंगे। तो यार ज़्यादातर ट्रेडर इस तरीके से पहले तो नुकसान करते हैं। अगर लॉस बड़ा है और प्रॉफिट छोटा है तो आप कभी सर्वाइव नहीं कर पाओगे। अब ये सब बाकी
All right, so you want to improve your strength for pull-ups. You came to the right place.
Get it very easily. Of course, I realize that may be very different, doing it outside the country, and Alaa will be better qualified to speak about this.
Well, this is the other thing that I talked about. You need to share the plan between the international organization and the local organization, because they know better than you how to deal with these issues, and also to deal also with the key people, the Ministry of Health, the university hospital, that can have access to all these logistics. For example, when we go to Tanzania, when we go to Kenya, we deal with the Ministry of Health, and they take the implants for they know who are the companies that deal with the implants and the agents, and they take care of all these logistic issues. Otherwise, it's not that you will deal with everything. The way that some organizations would do, just having 20 people coming to the country with all the implants and everything, they might work once, but it doesn't work because you are out of the context. You need to do the things within the context, and because of that, it's mandatory to deal with the key organizations, local organizations, and get them being responsible with you about the whole process.
Perfect. Thank you, Dr. Alaa. I have a question for Dr. Andrew. Dr. Andrew, you have a lot of experience in dealing with crisis situations, and Dr. Peter was talking about innovative solutions, innovative options in managing these areas. In your experience, what are the kind of innovations that you have seen in person in execution in these areas?
Well, I guess currently the situation in the world with conflict in Ukraine and in Gaza, what we're seeing is a lot of limb trauma, and limb salvage surgery is becoming more and more of an issue. And I think working alongside our colleagues in orthoplastics and plastic surgery, bringing specialists into country to train local surgeons in simple orthoplastic techniques. As you've heard today, there's no point in doing ultra complex surgery, but disseminating and training local surgeons in using simple techniques like local skin flaps has proven very, very effective in preserving limb length. And the other thing is using our rehab teams to come in at an early stage and get involved with rehabilitation as early as possible. And so now we're deploying, where possible, with rehabilitation specialists on board as part of our team. Thank you.
Thank you very much, Dr. Andrew. Dr. Arindam, we are talking about educating orthopedic surgeons in the locality, do you think reverse outreach, as in having the local orthopedic doctor coming and assisting you for maybe a couple of days, and then going back and you travel with him and go and serve the patient will be good? Maybe is it a good idea? Maybe he can carry out the follow-up of the patients later.
Yeah, it depends on the surgery you're doing and the center where it's being done. So you need to make sure that it's not done in a inappropriate center. So if you're doing some surgery which needs a very clean environment, then you need to ensure that the center where you're doing it is appropriately cleaned and sterilized, because we do a lot of outreach programs in various districts, and the main thing is, again, the planning, which has to be done before anything else, just to make sure that the people who are manning, maybe if you're working in going to a nursing home, you have to ensure that that nursing home is doing things, keeping equipment properly and sterilizing. I think sterilization is a very important thing, because I've seen a lot of nursing home where the process is very, very lax. People are just walking into theater and walking out, and they don't realize the gravity of, because orthopedics is very unforgiving for infection, and we need to be very careful. Same with equipment. And again, if in a remote center, you don't want to be caught without appropriate, equipment. Say if you have a specific type of screwdriver which you need and you don't have it there, it's nothing you're going to be able to do. So again, the planning behind the scene is most important, and you need to really think it through, that what are the problems you could face.
Thank you, Dr. Arindam. I think surgical outreach is one area where you can definitely say failing to plan is planning to fail. And if you really want to outreach to a larger population or many generations, there are many levels of planning that are needed. Dr. Muhammad, do you have any questions, or any of the speakers, do you have any questions for each other?
Thank you very much. I think it was all clear, and all the presentation are well. So I don't have any questions right now.
Thank you very much for everyone for making your time for this wonderful presentation, which I'm sure will have a large outreach for many people. Thank you very much. And I would also invite all the audience to give your feedback to SICOT Pioneer on how this presentation was. And don't forget to join us for our next presentation on SICOT Pioneer, that is on rehabilitation and total hip arthroplasty, ulnar wrist pain, and don't forget to join us in Serbia, Belgrade for the SICOT Annual Congress. Thank you so much, everyone.
Thank you. Thank you. Pleasure being with you all.
Thank you all.
Thank you very much.
Thank you.
Bye. Bye-bye.